Today's class will be on filariasis. Very common disease all over the India, in particular our Godavari districts. Okay, so this is a big social problem. It's a social disease. It is psychiatric associated with a psychiatric illness. Lot of the last hours, working hours last. Okay, and then finally a sexual disease also, sexual problems, lot of the things. Okay, so now move on to the exact what you mean by the filariasis, how it occurs, what is the diagnosis, how is the treatment, and is there any vaccine, etc. So it's a parasitic disease caused by an infection with the roundworms of the Filariae type, spread by blood feeding black flies and the mosquitoes. Belongs to the group of the diseases called elephantiasis. 8 known filarial nematodes cause humans, use the humans as their definitive host. Okay, so not all are Wuchereria bancrofti. So we have 7 more filarial nematodes to cause the disease in the humans. Wuchereria bancrofti is the primary causative agent of the lymphatic filariasis. So we have the lymphatic filariasis, we have the subcutaneous filariasis, we have the serous filariasis, we have the skin filariasis. So there are the different subtypes of the filariasis are there, but most usually we consider as the lymphatic filariasis as the most important cause for our filarial diseases. So a lot of the people are there in the world and India infected with the filariasis. See, widespread throughout the subtropics and the tropics, mostly the Asia, Africa and South America. So more than the 80 countries, nearly 1.2 billion people are having the filarial diseases. 90% is because of the Wuchereria bancrofti and the remainder by the Brugia, malayi and other 6 serotypes of your filarial worms. So these are the endemic areas. India is also included. Lot of the people, they live in the endemic areas for the Wuchereria bancrofti with infection occurring over the 250 millions in India. It is estimated that 45 million people are infected with the Wuchereria bancrofti. Culex, Anopheles and Aedes mosquitoes, they are also the main vectors. Not only your Culex, but also the Aedes and the Anopheles. So they also cause the filariasis. The disease affects those living in the coastal states, especially the Kerala, Orissa, Andhra Pradesh, Tamil Nadu and Pondicherry. So this is the map of your filariasis. See, almost all the states in India except the northern states are infected with the filaria. India, Andhra is also included there. Mostly the total entire coastal Andhra is endemic for the filariasis, and see the limbs there, how the elephantiasis and etc. Lot of the people, millions of the people are infected with the filariasis. 90% of these infections are caused by the Wuchereria bancrofti and remaining by the Brugia malayi. Humans are the exclusive host for your Wuchereria bancrofti. Certain strains of the Brugia malayi can also infect some flies and the monkeys. Whereas in the central Kerala, some of the cases are there, filariasis is caused by the Brugia malayi. Whereas in our coastal Andhra, 99% by the Wuchereria bancrofti. What is the impact of the filariasis? So it can suffer from the lymphedema and elephantiasis in the men. A lot of the organs in the body will be involved with this filariasis, mostly the scrotum, lower limbs, upper limbs and breast. These 4 are the important parts which are involved with the lymphatic filariasis. So they cause the hydrocele. The most common cause for the hydrocele is the lymphatic filariasis. It is the leading cause of the permanent disability worldwide. Second common leading cause of the permanent disability in the world. Communities frequently shun and reject the women and the men disfigured by this disease. So that is the reason I am saying that it is a a big social disease. Affected people frequently unable to work because of their disability. So the loss of the working hours, lot, and this harms their families and their communities. Okay. So it's a group of the parasitic, it's a nematode infections caused by the flies. They share the similar life cycle, your life cycle in the humans, life cycle in the mosquitoes, but they differ in their vectors. So some are the culex, some are the anopheles, etc. The final dwelling place of the adult worms. So some stays in the lymphatics, some stays in the subcutaneous tissues, some stays in the serous cavities, some stays in the eyes, etc. The circadian periodicity of the microfilaria. If you take the Wuchereria bancrofti, the periodicity is a nocturnal. So that is the reason we check the blood sugar, peripheral smear examination at 10 p.m. and 2 a.m. Okay. The pathological syndromes they cause. They not only cause acute adenolymphatitis. Some people, they affect with acute filarial lymphangitis. There is a difference between acute adenolymphatitis and acute filarial lymphangitis. And you will have the chronic filariasis, and you have the hydrocele formation, and you have the tropical eosinophilia. Okay, so these are the different pathological syndromes are there. See, this is the species which cause the disease in the humans. Wuchereria bancrofti, the adult worms. So they live in the lymphatic vessels for a span of about nearly the 8 years. 3 to 8 years, these Wuchereria bancrofti adults live in the lymphatics. So microfilaria, they are in the blood. Brugia malayi, again they live in the lymphatic vessels. Microfilaria in the blood. So blood examination, peripheral smear examination is very important here. Onchocerca volvulus, it is a subcutaneous. So I told you 3 or 4 areas. One is the lymphatic vessels, and then the subcutaneous. Some are in the skin, some are in the tetraperitoneum, third space. Onchocerca volvulus, it's the subcutaneous. The microfilaria is the skin. Lova, it's the subcutaneous. The microfilaria in the blood. Mansonella persistens, it is the retroperitoneal. The microfilaria resides in the blood. Mansonella streptoceria, it is the skin, and the microfilaria is also in the skin. And Mansonella ozidi, it is the retroperitoneal, and both the blood and the skin. So don't think that filariasis is only the Wuchereria bancrofti. So more than the Wuchereria bancrofti, there are the different species are there. Adults, they live in the lymphatics, some they live in the subcutaneous tissues, they live in the skin, they live in the retroperitoneal areas, and microfilaria will be seen in the blood, in the skin, and also blood and the skin. So the spectrum of the illnesses of the filariasis, it could be asymptomatic. So they don't develop any fever, they don't develop any lymphadenopathy, they don't develop any hydrocele, they don't develop any pulmonary eosinophilia, but they are asymptomatic and subclinical. So if you check the blood, the microfilaria will be there. So that is an asymptomatic one. But they are circulating microfilaria. And acute, you will have the two, acute adenolymphatitis and acute filarial lymphangitis. So acute adenolymphatitis, the people will present with the fever, they will have the lymphadenopathy. Okay, so that is the adenolymphatitis. And whereas the acute filarial lymphangitis, these people don't have the fever, they don't have any entry points, because acute adenolymphatitis, they will have the entry points. Entry points in the form of your fissuring in the skin, or skin cracks, or maybe the abrasions, or any ecchymosis, okay, or any paronychia. So these are the routes to enter the bacteria to cause the acute adenolymphatitis. Okay, in filarial lymphangitis, they don't have the fever, they don't have any entry points, but they have the string sign. String sign means the total lymphatic system will be dilated because of the worms in the lymphatic tissue, lymphatic vessels, and that is called as the string sign. So that is the difference between the acute adenolymphatitis and acute filarial lymphangitis. So the entry points will be there in acute adenolymphatitis, and string sign will be positive in acute filarial lymphangitis. A chronic form, yes, there will be the lymphatic obstruction leading to the lymphedema, and this is a vicious cycle. So every time they get the inflammation, etc. So there will be the damage of your lymphatic vessels, maybe the endothelial dysfunction, etc. And then they cause the lymphedema. And again in the next insult, again there will be much more lymphedema. And finally the skin will be thickened and there will be the nodules, there will be the fissures, and there will be the new growths in the skin and moisture preparations, etc. And of course, hydrosis is very, very common. And some people will have the epidermoarthritis, elephantiasis of the limbs, not only the lower limbs mostly, and some people they were present with the upper limb also. So the filarial left upper limb, filarial right upper limb, they are also common in our area. And there is the episodic adenolymphangitis with the filarial fever. And cryptic form, they cause the lymphatic and the renal pathology and the tropical pulmonary eosinophilia. So this tropical pulmonary eosinophilia is because of the derangements in the immune system. So there will be hyper-responsiveness to the antigens of these microfilariae, and then they cause a lot of the changes in your lymphocytes, and finally these people will have tropical pulmonary eosinophilia. See, if you see the worms, as I told you, they live for very long years, maybe 2 to 8 years. It's a white, slender, round worms. 3 types: bancrofti, Brugia malayi, and Brugia timori. Live for 5 to 7 years, or sometimes even 8 years. They produce the millions of the offsprings. So they are microfilariae. Okay, millions and millions of the microfilariae will be produced from your adult worms. And this adult worm is length is somewhere between 5 to maybe 20 millimeters. So that means 0.5 to 2 centimeters in female worm, whereas the male worm is half of that size, maybe 2.5 to 1.5 to 2.5, etc. like that. Okay. So female Wuchereria bancrofti worms are much longer and thicker when compared to the male Wuchereria bancrofti. They block the lymphatic systems, network of the channels and lymph nodes that help them maintain the fluid levels in the body. Blockage leads to the edema, that is the lymphedema, lymphoria, etc. So the mosquitoes are the vectors and they spread the infection. A mosquito is the intermediate host and the carrier. The most common vector or carriers in Africa is the Anopheles. In our India, it is the Culex, and also in the America. In the Pacific and Asia, the Mansonia and its species are also responsible for that. So Culex, Anopheles, Mansonia, and Aedes aegypti. See, I told you adult female Wuchereria, it is about 80 to 100 mm. That means 8 to 10 centimeters long and 0.24 to 0.3 millimeters in the diameter. Whereas the male is about 40 mm. That is 4 centimeters, half of that size. Okay. Here female domination, Wuchereria bancrofti. How the larvae appear? A microfilaria is about 240 to 300 micrometers long, and you need not remember these figures, but it is a sheathed one, microfilaria, and it has a nocturnal periodicity. Okay, so that is the reason at 10 p.m. and also the 2 a.m. we get the peripheral smear examination to identify the microfilaria. Except the South Pacific microfilaria, which does not have a marked periodicity, it has a gently curved body and a tail that is tapered to a point. So curved and also tail is tapered. That is your microfilaria. Very, very small, 240 to 300 micrometers length. See, this is the larvae. The nuclear column, the cells that constitutes the body, is loosely packed. It can be seen individually under a microscope. They do not extend to the tip of the tail. So this is how it appears. This is the Mansonia, earlier one is the Wuchereria bancrofti. See the difference between the Brugia malayi and the larva of Wuchereria bancrofti. So this is like a E, Roman E, Wuchereria bancrofti. Here the Brugia malayi is not like that. Infective larvae, they are transmitted by the infected biting mosquitoes during a blood meal. Okay, So during a blood meal, they liberate the larvae, infective larvae, that is larvae 3. So these larvae migrate to the lymphatic vessels. So once this Culex mosquito bites the person, it liberates the larvae, infective larvae, that is the L3 larvae. Then they enter into the body and directly they go to the lymphatic vessels and the lymph nodes where they develop into the microfilariae and then producing the adults. These adults in the lymphatic vessels and the lymph nodes where they can live for several years, maybe 5 to 8 years. Then the female worms produce the microfilariae which circulate in the blood to cause your fever and you cause your tropical eosinophilia, to cause the elephantiasis, lymphedema, hydrocele, etc. So the microfilariae infect the biting mosquitoes inside the mosquito. Again, these microfilariae, when the mosquito bites, these microfilariae enter into the mosquitoes. So they develop into 1 to 2 weeks in the infective form of the larvae. During the subsequent blood meal by the mosquito, then the larvae infect the human host. So they migrate to the lymphatic vessels and the lymph nodes where they develop into the adults. So this is the life cycle. See here, the mosquito injects to infective juveniles when it feeds. Then the juveniles migrate to the lymph nodes, grow to the sexual maturity, the male and the females. Then the females produce the microfilariae, which end up into the bloodstream. And then the vector, a mosquito, ingests the microfilariae when it takes a blood meal. Then these microfilariae develop into the infective juveniles in the mosquitoes. That is how the cycle goes on. So here the same thing. So in the head and in the proboscis, these infective larvae will be there. Then when it bites the human beings, see, it liberates the infected larvae. Then they become the adult forms, and then cause the lymphedema, etc. And then the mosquito bites. These microfilariae enter into the mosquitoes, and then first into the thoracic duct, and then into the head and the proboscis to cause the infective larvae. So this is the beautiful life cycle of the Wuchereria bancrofti. See the number 1 at the top at the 12 o'clock position. The mosquito takes a blood meal. So then these microfilariae, male and the female, adults in the lymphatics, see the sizes. So the big one and the larger one is the female, and the small one, thinner one is the male. Then they became the adults, adult worms in the lymphatics. And the adults produce the sheathed microfilariae and migrate to the lymph and the lymph channels, the lymphatics. It's the sheathed one. Okay, see the 4th one. The mosquito takes a blood meal and these microfilariae will enter into the mosquitoes. So what will happen in the 5th step? The microfilariae, they have the sheath earlier in the humans. So once it enters into the mosquito, they shed the sheaths and penetrate the mosquito's midgut and migrate to the thoracic muscles. Then the 6th one, then the larvae formed, that is the level 1 larvae, and then the 7th one is the level 3 larvae. I have not seen the level 2 here. So level 1 and the level 3 larvae. And level 3 larvae migrate to the head and the mosquito's proboscis, and then in the next meal and the next bite, and these larvae, the infected larvae, level 3 larvae, will enter into the human body. So that is how the life cycle of the Wuchereria bancrofti occurs. So am I clear? So this is the Brugia malayi. Now the life cycle in the man and in the mosquitoes. Okay. See the life cycle. Adult worms cause the fibrosis and inflammation of the lymphatics, non-pitting lymphedema. So the edema here is the non-pitting edema. So earlier the skin is healthy, shiny. Later non-pitting edema, then the skin becomes a thick, and finally there will be fissures in the skin, breaks in the skin, and then the hyperpigmentation of the skin, then the nodule formation, moisy formation, and etc. Everything will be occur there. So what is the pathogenesis of these filariasis? The live adult worms inside the lymphatic dilatation and proliferation with edema formation. The dead worm induces the obliterative changes resulting in the mechanical blockage of the lymphatic channels. So after the 8 years or the 7 years, These adult worms, they die. Then after the death of these worms, then they give a reactionary things in the lymphatics. The regional lymph nodes enlarge due to the humoral and the marker's immediate reactions, and then the subside. Obstructive features develop only when the exposure continues for the many years. The same thing. So there will be the complex interplay of the pathogenic potential of the parasite, the immune response of the host, and the external bacterial and the fungal infections. Okay. So why the bacterial? Because the skin is shiny, the skin is not healthy, and there is a hypertrophy of the skin, there will be the fissuring in the skin. So definitely a lot of the fungi and also the bacteria will enter into the body, and then they cause the infections. So that is the lymphangitis. And this cycle goes on, and totally there will be the elephantiasis of the limbs will occur. So there will be the genital damage, that is your hydrocele and the lymphedema and the elephantiasis and lymphoria. So men can develop the hydrocele. Usually, these microfilariae enter into the body at the age of 3 years, 4 years, or 6 years, or 7 years. Maybe less than the 10 years of age group. These infected larvae enter into the body. But they develop these hydrocele and the tropical pulmonary eosinophil, etc. post-pubertal. So that means there may be a gap of nearly 10 to 15 years or some 20 years or 30 years are also there between the entry of these infected larvae into the body and appearance of your symptoms or the signs of the disease. Say a very big incubation period is there here. The filarial infection can also cause the tropical pulmonary eosinophilic syndrome. Although this syndrome is typically found in the persons living with the disease in Asia, symptoms of the tropical pulmonary eosinophilia syndrome include cough, shortness of the breath, and wheezing. So looks like your bronchial asthmatics. The eosinophilia is often accompanied by high levels of the immunoglobulin E and antifilarial antibodies. Okay, so this almost the presentation is like asthmatic, and if you check the IgE, so that will be very much elevated. In adults, maybe more than 100. Some people may have 800, 900, even 1000 also. And if you see the histologically, there will be the dilatation and proliferation of the lymphatic endothelium and abnormal lymphatic function. Non-inflammatory pathway, inflammatory pathway, adenitis and retrograde lymphangitis, bacterial and the fungal superinfections are also common. See, in the non-inflammatory pathway, in your acute filarial lymphangitis, whereas inflammatory pathway in acute adenolymphangiosis. So the disease manifestations are due to the lymphatic dysfunction resulting from the presence of the living and the dead worms, lymph thrombi, inflammation, and immune reactions to the worms and the worm products. So that is the result. We are getting the disease. Okay. So here the immune system is involved. There will be the lymphatic obliteration or inflammation or thrombosis or endothelial dysfunction of your lymph vessels. They will be there, and there will be the defective immune system in chronic filariasis. So what are about the clinical features? So they are chronic mostly, and sometimes in acute. Some people know with the filariasis, every year they get the cellulitis. Maybe in the month of October or November or December, cellulitis of the lower limbs. So because of the entry of the bacteria in these areas. So there some are chronic, some are acute and chronic, some are asymptomatic. They have only the microfilaria. They don't have any symptoms. So these are all the presentations of the lymphatic filarial disease, as well as some syndromes associated with these infections. Among the chronic manifestations, hydrocele, even though found only with the Wuchereria bancrofti, not in the Brugia infections, is the most common clinical manifestation of lymphatic filariasis. See, the chronic most common is the hydrocele, elephantiasis, chyluria. This is very, very common. So that is almost the urine looks like white urine. That is our chyluria. Acute manifestations, acute inflammatory episodes, filarial fever, eosinophilia, acute inflammatory reaction. So some are asymptomatic presentations. Other syndromes. So far we discussed about your hydrocele or epididymoarchitis or the breast lymphangitis or lymphedema in the lower limbs, etc. And also in the lungs in the tropical pulmonary eosinophilia. But arthritis, usually monoarticular. See, the monoarticular arthritis in India, infections, tuberculosis is very common. So the tuberculosis of your knee joints or tuberculosis of your spine, etc. But here again, here you should also think of the filariasis as a cause for your monoarthritis. Endomyocardial fibrosis, tenosynovitis, thrombophlebitis, glomerulonephritis, and lateral popliteal nerve palsy, and these are the important other syndromes other than your lymphatic filariasis or tropical pulmonary eosinophilia. So these are also maybe caused by the filariasis. So as a postgraduate medicine, so you should also think of these things. So could be a monoarthritis, and then endomyocardial fibrosis, tenosynovitis, thrombophlebitis, glomerulonephritis, and lateral popliteal nerve palsy. While lymphedema can develop into the absence of the overt inflammatory reactions and in the early stages be associated with the microfilaria, the development of elephantiasis, either of the limbs or the genitals or the breast, is most often associated with the history of recurrent inflammations. So there will be a cycle of these infections every year. The early pitting edema gives rise to a stronger edema with the hardening of these tissues. So earlier the skin is shiny, non-pitting edema, and finally you can see the skin of these filarias, how it looks. Sometimes it's very dirty, and sometimes it's completely associated with a lot of the infections and etc. So though it damages the lymphatic system, the most infected people have no symptoms and will never develop the clinical symptoms. These people do not know that they have the lymphatic filariasis unless they're tested. So a small percentage of the persons will develop the lymphedema. Fortunately, most of the people here, they are the asymptomatic or subclinical. So the disease manifestations caused by the fluid collection because of the improper functioning of your lymph system resulting in the swelling. So damaging the lymphatics. So there will be the defect in the proper flow of your lymph. So the fluid collection will be there, the lymph collection will be there. So this mostly affects the legs. So there will be elephantiasis of the legs, but can also occur in the arms, breasts, and the genitalia. So we are seeing all these areas in our places. So both the lower limbs, both the upper limbs, breasts in the female, and hydrocele in the males is a very, very common presentations. Most people develop these symptoms years after being infected. I told you, usually they get the infection less than the 10 years of the age group, maybe less than the 15 years of the age group. By the time the presentations, the manifestations occur maybe 25 years, at the age of 25 years, or the 30 or the 40 years. What is elephantiasis characterized by? There will be the thickening and the hardening of the skin, increased body size due to the masses of the worms all over the body, especially in the nose, eosinophilia, heart failure, and the breathing difficulty. Decrease of the blood flow due to the worms inside the blood vessels, blockage of the lymph fluid due to the worms inside the lymph vessels, masses of the microfilaria in the skin tissues. Now move on to the tropical pulmonary eosinophilia. Say the distinct syndrome in some individuals, paroxysmal cough and the wheeze. Okay. Weight loss, low-grade fever, a pronounced blood eosinophilia, total serum immunoglobulin E and antifilarial antibody titers are raised, responds well to the treatment, but in its absence, progressive pulmonary damage. See the symptoms here. Okay. Sometimes people may have the fever. Some people they may have the kidney damage also. Glomerulonephritis. We discussed. Okay, glomerulonephritis. Skin abnormalities may be due to the bacterial infections. Elephantiasis, swelling of the limbs and the genitalia. Enlargement of the scrotum. Penis is retracted under the skin. Spermatic cords are very much thickened. Long tumorous mass covered by the thickened ulcerated skin develops on the vulva. So they are very common in genital areas, filariasis. It's the preclinical phase. So incubation phase is the time between the infection and the first appearance of the microfilaria. Until then, the individuals are usually asymptomatic and a microfilariamic. Asymptomatic microfilariemia is there But the only diagnosis is confirmation by your peripheral smear examination. So the clinical phase, already I told you the intermediate acute lymphatic inflammation. There will be the lymphangitis, tender cervical, epitrochlear, axillary, inguinal lymphadenopathy. So it depends on the lower limbs are involved, you will have the inguinal lymphadenopathy. If the upper limbs are involved, you have the axillary lymphadenopathy. And the breasts are involved, maybe the epitrochlear and the cervical. The part involved is usually the lower limb or the scrotum. ADL, that is the acute adenolymphangitis, is the commonest and the most seen of the various manifestations of filariasis. It is also called the filarial fever or acute filarial disease. Episodic attacks are often localized to the genitals and can present as acute epidermolysis or inflammatory nodules of the scrotum or the subcutaneous tissue in the males or the breast in the females. The symptoms: fever, chills, nausea, vomiting, loss of appetite, asthenia, etc. Some people will have the funiculatus, hydrocele, blockage of the vasa differentia leading to the sterility, so infantile, tropical pyomyositis, the filarial abscesses around the dead worms. So these are the things. So not only your lymphangitis and the tropical pulmonary eosinophilia, glomerulonephritis, here the abscess formations. Okay, so these are also, and monoarthritis, tenosynovitis. So these are also very common. So the hydrocele, due to the accumulation of the fluid as a result of the blockage of these lymphatics, lymphedema. So recurrent episodes of the scrotal skin and the limb edema develop, which are initially pitting and subsequently become a non-pitting due to the loss of the skin elasticity and fibrosis. Legs are more commonly affected than the arms. Wuchereria bancrofti infection, the swelling involves the thigh, while in a Brugia malayi infection, the leg is swollen. So the leg only in the Brugia malayi, whereas the Wuchereria bancrofti, whole lower limb or the whole upper limb, including the breast and the genitals, may be involved. So there will be the destructive changes, damages in the lymphatics, disfiguring changes of elephantiasis, not only in the arms, legs and the scrotum, vulva and breasts in the female. Elephantiasis can occur with or without the repeated attacks of the adenolymphangitis. Chyluria, that is also very common. Painless excretion of the chyle in the urine due to the lymph reflux from the pelvic calcareal system resulting from the rupture of the renal lymphatics. Microfilaria may or may not be present in the urine. Large quantities of the dietary lipids, protein and fat-soluble vitamins are excreted, leading to severe weight loss, debility, malnutrition, so hypoalbuminemia, etc. So that is the chyluria. So now can grade the lymphedema in filariasis, grade 1, 2, 3, 4. 1, pitting edema, spontaneously reversible on elevation. So that is the grade 1. It is reversible on elevation. Grade 2, non-pitting edema, not reversible on the elevation. Grade 3, a gross increase in the volume with a marked thickening of the skin with a sclerosis and papillomatous lesions. So there will be the hyperpigmentation of the skin, discoloration of the skin. Skin is very thick. So there will be the papillomatous lesions and the sclerous lesions. And grade 4, ulceration. So presence of the ulceration is very common in our areas. So the filarial legs with ulcerations. So that is the grade 4. Complications of this lymphatic filariasis. So left untreated, what will happen? So some people, they present with thrombophlebitis, tenosynovitis, nerve palsies, dermatosis due to lymphatic fistula formation into the synovial sac from lymphangiectasia and stasis in the populated lymphatics. Pericardial fluid, so your pericardial effusions. Glomerulonephritis, it's immune-mediated vasculitis. Monoarthritis involving the knee joints. Endomyocardial fibrosis due to the pericarditis. And ocular filariasis causing iridocyclitis. See? So almost all, it is almost like a systemic disease, filariasis. So even though the lymphatic filariasis is the most common thing, so that may involve the ophthalmology, so that may involve the neurology, it may involve the pulmonology, cardiology, etc. Okay, so it's a systemic manifestations of the filariasis is also there. See the hydrocele here. See, these are the African people. See the extent of these things. Limb, skin is very much thickened. See the second toe, great toe. So the ankle region, the skin. Okay. So until very recently, the diagnosing the lymphatic filariasis had been extremely difficult. Since the parasites had to be detected microscopically in the blood, and in most parts of the world, the parasites have a nocturnal periodicity that restricts their appearance in the blood to only hours around the midnight. So practically it is not possible to get the peripheral smear examination at 2 a.m. or 3 a.m. Okay, so that is the reason the diagnosis is very, very difficult, extremely difficult to diagnose the microfilaria in the blood because of this nocturnal adiposity. See the nocturnal periodicity, the worms can only be detected in the blood of those infected around the hour of the midnight. New specific card test detects the parasites using only finger prick blood test any time of the day. Ultrasound can identify the rapidly moving adult worms. Sometimes no, ultrasound can pick up the adult worms of your Wuchereria bancrofti. Okay. Depending on the direct demonstration of the parasite, antigen detection, you have the circulating filarial antigen, gold standard for diagnosing Wuchereria bancrofti. See, this is how they detect. Stained thick smear blood film is drawn using the blood drawn in the night between 11 p.m. to 2 a.m. Whereas for the malarial parasite, you need thick and thin smears. Okay, thick smear to detect whether the malaria is there or not, and the thin smear to identify the species, whether the vivax or the falciform or malaria or oval, etc. Whereas here, only the thick film is needed. The differentiation between the various filarial species are based on the morphology of their sheaths. I told you in the microfilaria, they are the sheathed one as long as they are in the human body. Once these microfilaria enter into the mosquitoes, then they shed the sheaths and then they become the larvae, L1 and then the L3 larvae. That is the infective larvae. Eosinophilia usually absent except during the episodes of the acute inflammation and in the early stages of the illness. Usually you don't find the eosinophilia in filariasis. Contrast lymphangiography to be avoided as it can damage these delicate vessels. So already the lymphatics vessels, they are very, very delicate, and the contrast may damage these lymphatics much further. Ultrasonography is very, very good because non-invasive. It can visualize the living adult worms in the lymphatics. Lymphoscintigraphy scanning using the radio-labeled albumin diagnosis using antigen and antibody detection assays for bancrofti and Brugia. Circulating filarial antigen of the living adult worm in the finger prick blood specimens can be detected by the monoclonal antibodies. So these serology techniques, they provide an alternative to the microscopic detection for the diagnosis of your lymphatic filariasis. The patients with the active filarial infection typically have elevated levels of the antifilarial IgG4 in the blood, and these can be detected using the routine assays. Now coming to the treatment aspect. Communities where filariasis is the endemic. The primary goal of treating the affected communities is to eliminate the microfilaria from the blood of the infected individuals so that transmission of the infection by the mosquito can be interrupted. But it is very easy to say, but very, very difficult to perform. Treating the infection, you have the three drugs here: diethyl carbamazine, ivermectin, and albendazoles. So even the ivermectin and the albendazole, they are not the antifilarial drugs, but they are very much useful in the management of the filariasis. So the very true antifilarial drug is the DEC, diethyl carbamazine. Big thanks to our Yella Pragat Subbarao gar. Okay, he invented this drug. So 6 milligrams per kg per day is the dose of your diethyl carbamazine for 12 days in Wuchereria bancrofti filariasis and for 6 days in Brugia malayi filariasis. Repeated 1 to 6 monthly intervals if necessary. Okay, so that is how you have to treat with the DEC. Now the heterozole or your eophil or your banoside, so they are available in the strength of 100 milligrams or fort, that they contain about 250 milligrams. Okay, so the 6 milligrams per kg body weight. Suppose the person is about 60 kgs, so he needs nearly 360 milligrams per day. Now the ivermectin is also there. It's a single dose usually. Albendazole, again it is a single dose. Side effects: headaches, fever, myalgia, lymphadenopathy, and occasionally rash and itching. Now the triple drug combination. So combination therapy is very much needed in our filarial management also. No single drug in filarial management. All the 3 drugs has to be given according to the WHO Indian guidelines. So all the 3 drugs, what are they? Diethyl carbamazine, ivermectin, and albendazole. All the 3 should be used as a combination therapy in the treatment of lymphatic filariasis. So the prevention is very important. The mosquito nets, insect repellents, healing techniques, elevate and exercise the affected body part. So the elevation will reduces your edema. Skin treatment, wash the area twice daily. This is very, very important. So the hygiene, so personal hygiene or the leg hygiene or genital hygiene is very, very important to not to spread the filariasis. Antibacterial cream if the skin is damaged or the cracks or etc. A complex decongestive physiotherapy, a lymph drainage, massage, compressive bandages, all this will help the individual so not to spread the disease and also to avoid the bacterial entry into the bodies. So the currently used antifilarial drugs, DEC and ivermectin, here you can also add albendazole. So DEC, ivermectin plus albendazole for our Indian patients. So this is the African slide. Okay, see the fellow. He is not from India, he is from South Africa. They are useful against the larval offspring, DEC. Doxycycline, tested on a Tanzanian village, found to almost completely eliminate the adult worms 14 months after the treatment. Sustained loss of the larval offspring for 18 to 14 months after the treatment. So the doxycycline is also useful as an antifilarial drug. Albendazole and the DEC given together once in a year, found to be 99% effective in removing the microfilaria from blood for a full year after the treatment. So our Indian government is also doing this work. So once in a year, antifilarial treatment with your DEC and etc. So both albendazole and the DEC, they have been shown to be effective in killing the adult stage filarial parasites. It is clear that this anti-parasite treatment can result in improvement of the patient's elephantiasis and the hydrocele, especially in the early stages of the disease. Suppose if the person presents the late presentation and very little can be done. See, diethyl carbamazine discovered 50 years ago by our Yellaprakad Subbaragar. Big thanks to him. Ivermectin discovered in the 80s, both primarily microfilariacidal. DAC 6 milligrams for 12 consecutive days, along with antibiotics like penicillin or cotrimoxazole or doxycycline, plus anti-inflammatory drugs. A single dose to be repeated every 6 to 12 months. Ivermectin, a semi-synthetic macrolide antibiotic with a broad spectrum activity against a variety of the nematodes and ectoparasites. Single oral dose, 200 to 300 milligrams per kg, comparable to a 12-day course of the DEC. So in DEC, we give the 12 days. And again at once a day for about 6 to 12 months. Whereas ivermectin, a single oral dose, 200 to 400 milligrams. Lova is caused by the lova, transmitted to the humans, usually in the jungles by the day-feeding flies. So it is a transient subcutaneous swellings. They are called Calabar swellings. They are the localized subcutaneous edema caused by the live adult worms which move about, distributed around the wrists or the knees and recur in the same or the different sites. These worms are infrequently seen moving in the subconjunctiva. See the lova worm. So here the diethyl carbamazine, again the micro ivermectin. Here it should be given as a single dose only. There the diethyl carbamazine also. Whereas in an Wuchereria bancrofti, we give 12 days. So Onchocerca volvulus, it is the retroperitoneal areas. See the filariasis here. See the limbs. So the retroperitoneum, see the limb here. So treatment again here, diethyl carbamazine and the ivermectin. The prevention by decreasing the contact between the humans and the vectors, or by decreasing the amount of the infection, the vector can acquire population through the reducing the numbers of the mosquitoes. 2-drug treatment or the 3-drug treatment, the ivermectin, albendazole and diethyl carbamazine. Personal repellents, bed nets, that is very, very important, mosquito nets or insecticide impregnated materials. Prophylactic, diethyl carbamazine 6 milligrams per kg per day for 2 days each month. So that is the prophylactic dose. Okay. So 6 milligrams per kg body weight per day for 2 days each month. Once in a month, 2 days. So avoid the mosquito bites is the best form of the prevention. The mosquitoes that carry the microscopic worms usually bite between the hours of the dusk and the dawn. So if you live in or travel to an area with lymphatic filariasis, sleep under a mosquito net, wear long sleeves and the trousers, use mosquito repellent and expose your skin. So WHO was the strategy of the global program to eliminate the lymphatic filariasis. So in fact, a global program to eliminate the lymphatic filariasis, GPELF. So started in the year 2000. So their aim is to stop filariasis or to make the world free of the filariasis by 2020, but not possible. So not occurred. So still a lot of the filariasis cases. Now they extend up to the 2030. So that is their goal. By 2030, we should avoid or eliminate lymphatic filariasis. So the mass treatments, community treatments. So they are all the international guidelines. So it's a big economic and the social impact. In recent years, lymphatic filariasis has steadily increased. See, recent years, steadily increased because of the expansion of the slum areas and the poverty, especially in the Africa and the Indian subcontinent. So more breeding sites are provided for the vectors, some at urban civic interfaces. As many filariasis patients are physically incapacitated, it is also a disease that prevents the patients from having a normal working life. See, this is the impact. As I told you earlier, so the communities frequently shun those disfigured, inability to work, a sexual disability. Women with the visible signs may never marry, or spouses and families will reject them. So thank you very much for your patient hearing. So these are some of the photos here. See, this is interdigital candidiasis. That is how the bacteria and the fungi will enter. See, this is the earliest stage. So redness, non-pitting edema. See, the skin is, see the left lower limb. See the edema. See the mosy appearance. See the skin is very thickened, fissured. So thank you very much.